All right, let's dive right in. Today, we are tackling a really important topic: breast cancer risk. It's something a lot of us think about, but the real factors that actually shape that risk, they're way more complex than you probably think. So, we're going to break it all down.
So, what truly determines your risk? Really, it's definitely not just one thing. And honestly, some of the stuff you hear all the time doesn't even begin to tell the whole story.
The reality is, your risk is this kind of crazy combination of your body's hormonal history, the genetic cards you were dealt, and it's all happening in a field that's full of some pretty serious scientific debate. So, we're going to unpack each of these building blocks one by one.
First up, and you could argue this is the biggest piece of the whole puzzle, is what we're calling the estrogen equation. This idea is basically the foundation for a huge number of risk factors. Okay, so here's the core concept, and it's super important to get this. Lifetime estrogen exposure. The easiest way to think about it is like a running clock. The longer that clock is ticking over your lifetime, the higher your risk gets. It's a simple idea, but it connects so many different things, like when your period starts and even when you have kids.
And this just lays it all out. All the ways that clock can get more time added to it. Started your period early, or maybe you're going through menopause late? Well, that adds time. Not having kids or having them later in life means you have more of those uninterrupted estrogen cycles. Now, the source material is pretty blunt here. Being overweight increases estrogen because of an enzyme in fat cells called aromatase, and heavy drinking messes with how your liver breaks estrogen down. And then, of course, taking hormone replacement therapy that includes estrogen is literally adding more fuel to the fire. Okay, but it's not all about hormones. Beyond our lifestyle and what happens in our lives, there are risks that are just kind of written into our biology from day one. And this is where it gets really, really stark. Just look at this. The baseline lifetime risk for a woman is sitting at about 8%. But look what happens when you factor in family history. If you have one first-degree relative, so a mother, sister, or daughter, your risk jumps up to 13%. Two first-degree relatives, it skyrockets to 21%. That is nearly triple the baseline risk. And then, when we start talking about specific genetic mutations, the numbers just become staggering. For someone with a BRCA1 mutation, we're talking a 72% lifetime risk of breast cancer. 72%. BRCA2 is right there with it at 69%, and that's also a huge risk factor for men. Then you've got these other syndromes, like Li-Fraumeni, where a problem with a p53 gene leads to, and I'm quoting the source here, cancers literally everywhere. Or Cowden syndrome, with a whopping 77% risk on top of a bunch of other issues. So beyond family and specific genes, there are other really crucial factors. Having dense breasts, for example, is a big independent risk factor, and it's dose-dependent, which is just a fancy way of saying the denser the breast tissue, the higher the risk. Simple as that. Having a history of certain high-risk lesions. Those are basically pre-cancer cells a doctor might find on a biopsy. That also puts you in a higher risk category. And then there's radiation. And the important thing here is that this specific risk is actually quantifiable. So for patients who had radiation to their chest when they were younger, maybe for something like lymphoma, doctors have pinpointed a specific threshold, 20 gray. That's a precise dose of radiation. And if you receive that much or more, you automatically qualify for way more intensive screening, like getting an MRI every year starting much, much earlier than everybody else. So how do doctors take all these different pieces, estrogen, genetics, breast density, and somehow turn them into a single usable number? Well, they use these complex things called risk models. But as we're about to find out, these tools are far, far from perfect. Here are the two heavyweights in the game. The Gail model, that's the old-timer, it's been studied the most. Its whole thing is your personal history. But it has a massive blind spot. It doesn't factor in genetics at all. Then, on the other hand, you have the Tyrer-Cuzick model. People often call this one the most comprehensive because it does dig deep into your family history. But guess what? It leaves out breast density, which, as we just saw, is a huge independent risk factor. And I just love this quote from our source material. It just captures the feeling perfectly, right? It's like the author is saying, look, I know this is complicated and messy and honestly even a little frustrating, but you gotta know it. It's just so real. And here it is. This is the single most important thing to remember about all these fancy models. Because every single one of them has blind spots and can't possibly account for everything. They almost always underestimate a person's true lifetime risk. They're a starting point, for sure, but they are not the final word.
Okay, now that we've got our heads wrapped around risk, let's talk about what we do about it, which is screening. And you might think this is all settled science, but it is actually at the center of a really fierce, ongoing battle in the medical world. To set the scene here, our source uses some pretty dramatic language. This is how it describes a huge 2012 study by a statistician named Gilbert Welch. That study basically dropped a bomb on the world of screening mammography by seriously questioning how effective it actually was. And the author just keeps going with this hilarious satirical quote, painting Welch as some kind of dark wizard of data. Obviously, it's a joke, but it perfectly shows you how passionate and almost personal the arguments get on both sides of this debate. You have one side that believes screening saves countless lives, and another that argues it leads to a ton of overdiagnosis and treatments that people never needed. So, what's the bottom line? Well, there's the textbook answer, and then there's the real-world answer. For any exam you might take, the simple answer is screening saves lives. But in the messy reality of real-life medicine and research, the debate over its true benefits versus its harms is very, very real, and it's nowhere near being settled. Okay, that was a lot, I know. We went from hormones to genes to a full-blown scientific controversy. So let's just boil this all down into the most important things you need to walk away with. Here are the keys. Number 1, more estrogen equals more risk. Simple as that. Number 2, breast density is its own separate risk factor. Genetically, remember, BRCA1 is more common, but BRCA2 is the one to really watch out for in men. When it comes to risk models, Tyrer-Cuzick is the best we've got, but don't forget it misses breast density. That 20 gray radiation dose, that's the magic number for getting early MRIs. And finally, exercise, mostly because it reduces body fat and therefore estrogen, is very likely to reduce your risk. So we're left with a pretty complex picture, aren't we? Risk isn't just a single number. It's this whole web of interconnected factors. And our main tool for finding cancer early is something that experts are intensely debating. It really forces you to think about it on a more personal level. So, given all this complexity, what does prevention truly mean to you?